Hello, and welcome to this episode of In Discussion With from PharmacyUpdateOnline. Today I'm talking to Dr. Alexander Tzabazis about perioperative pain relief. Dr. Tzabazis, could you start by introducing yourself?
My name is Alex Tzabazis. I'm a senior consultant for anesthesia at the University Hospital in Lübeck, Germany.
We're talking about enhanced recovery after surgery. So my first question is, what is the goal of enhanced recovery and how does it differ from traditional approaches?
Enhanced recovery after surgery is a really hot topic right now, and there are protocols for almost any kind of surgery that you can imagine. The overall goal for enhanced recovery after surgery is to reduce perioperative complications and to bring patients back to their normal day life as fast as possible. But we don't want to sacrifice that by having more complications. So it's a better first and then fast approach, really.
Better first, then fast. Could you explain a little bit more about that?
That's right. So we want to get the patients out of the hospital in better shape than they would be after a traditional approach. But that does not necessarily mean we need to get them out of the hospital faster than usual. So if they have to stay as long as they used to with the traditional approach, that's fine. But the overall and very first objective is to get them out of the hospital in better shape as they were with a traditional approach.
Could you describe for us the various approaches that can be used in perioperative pain relief?
Absolutely. There's a multitude of approaches that can be used for perioperative pain. First of all, obviously, we still have the big area of regional anesthesia. That could be, for example, an epidural catheter placed or nerve blocks, or also continuous nerve catheters for postoperative pain management. But then we have the big approach of systemic analgesics, opioid analgesics, but also non-opioid analgesics. Those can be given on a timely basis or continuously using a syringe pump, for example. We can also give intravenous systemically local anesthetics, such as IV lidocaine, that has been used in the past. We have the big group of non-opioid analgesics, so that being ibuprofen, acetaminophen, or paracetamol. But then there's also newer additions, such as the gabapentinoids. We also have ketamine. That's a drug that is increasingly being used in perioperative pain management. And then we also have the alpha agonists, such as clonidine or dexmedetomidine. So we have really a huge armamentarium to treat perioperative pain from all kinds of different angles, and we should really use the best approach for individual patients and their respective surgery they're having.
Could you give us an example of how this might be used in practice? I mean, would one patient need a bit of everything?
Well, not necessarily. You really need to tailor your approach to your individual patient and to the type of surgery that this patient is having. For example, if a patient is having a big abdominal surgery with a big midline incision, our traditional approach with placing in a preoperative epidural catheter is still valid, and we would still use that. However, we are now increasingly using a multimodal pain approach where we add IV or oral analgesic drugs as well. And that is not only opioids, but also increasingly non-opioids. Some people have called this a maximodal approach, where we kind of try to mix together all the different analgesics that we have available almost, just to reduce side effects from that one single medication that we're having. And that is usually because of the opioid crisis that we're seeing. Usually we're trying to reduce opioid requirements in the immediate postoperative and also in the long-term postoperative period.